I feel highly privileged to be standing in front of you this morning. And my task is to be talking about highlighting the treatment gaps and challenges, including policy issues that impact access. So I think this is day 3, and we have had a lot of discussions around, some of these issues that we want to talk about. So they have sort of made my work a bit lighter, because I'll sort of be repeating some of the things that we have already had in some of the sessions over the past few days. So this is my conflict of interest declaration, and this is going to be my presentation outline. So just to begin with, I'll just define a few terms just to make sure that we are flowing in the same wavelength. When I'll be talking about adolescence, I'll be referring to that phase of life between childhood and adulthood from ages 10 to 19 years. And you will see the abbreviation AL, HIV, quite often in the presentation. This will be talking about adolescents living with HIV. When I talk about HIV treatment gap, I'm referring to the difference between the number of people receiving antiretroviral therapy and the number of people that are eligible for treatment. And this is both those that are diagnosed and undiagnosed. And access to antiretroviral therapy, I'm referring to the ease at which HIV positive patient can receive medication. And then HIV criminalization, I'll be referring to the laws that either criminalize otherwise legal contact or increase the penalties for illegal contact based on a person's HIV positive status. So just a bit of background. Globally, we have 1.65 million adolescents aged 10 to 19 that are living with HIV. And as we have already heard, sub-Saharan Africa is disproportionately affected with approximately 90% of these cases. And when we focus on the treatment gap, it is approximately at 35% globally, and it is wider for the adolescents compared to the general population. So I have some visuals here that are showing tremendous success over the past years in rolling out of antiretroviral therapy in the general population and also in the adolescents. On the left, you are seeing rolling out of antiretroviral therapy amongst the general population, including adolescents and the elderly. And at rollout up to around 2022 was at 76%. But if you focus on the right, where we are looking at adolescents alone, you'll see that at rollout up to around 2022 was at 65%. So this means that the gap is wider for the adolescents compared to the general population. And even if you look at the years going backwards, the gap has always been wider amongst the adolescents. So when you look at some key insights and considerations that we should look at when focusing on adolescents, I won't dwell much on this. We had a very beautiful presentation from Professor Baker when she was talking about, adolescence being that period where many people begin to explore their sexuality, and as a result, access to sexual and reproductive health information and services become increasingly important. So we find that this is the stage again where adolescents experiment with new experiences and increased vulnerability, and some may experiment with injecting drugs, sexuality and sexual orientation, and some may actually be exploited sexually. So this is a stage where it's actually a window of opportunity which we can intervene early if we want to have success with addressing the treatment gap amongst this age group. So we have just seen a video here where the young people themselves were explaining the challenges that they experience, and there is no better way to try to get these challenges than hearing from the young people themselves. And we heard them talking about the issues that are affecting them, talk of losses, personal questions that they have, stigma, all the issues that affect their mental health, leading to alcohol and substance abuse and defaulting the medication. So when you look at the challenges that then impact antiretroviral therapy access, there are many, really difficult to compress in a presentation, but I tried to group them into internal factors, mostly those that we have heard from the young people. We also have external factors as well as policy factors, and I'll go into these in more detail, starting with the internal factors. We had the young people talking about stigma and discrimination, and stigma is just those commonly held negative beliefs among the general population that discredit a particular group of people. And in our case, we are talking about adolescents that are living with HIV. Then discrimination, these are the behaviors that then result from those beliefs. Then self-stigma among adolescents living with HIV occurs when a person takes in the negative ideas and stereotypes about people living with HIV and sees themselves in that way, and this can actually be 3 times more common than social stigma. And in a study that was done in Zimbabwe by Nicola Willis and their colleagues, published in 2020, it reported that 73% of adolescents living with HIV that were enrolled in their program experienced stigma that affected medication and adherence. So you find that stigma affects all the important outcomes that we talk of when it comes to HIV care and treatment. Then focusing on mental health, that we have heard again the young people talking about, we find that there is higher prevalence of common mental conditions amongst adolescents that are living with HIV compared to HIV unaffected adolescents, as shown by research. And these mental disorders are associated with poor HIV treatment outcomes, including poor adherence that then affects our treatment gap, and virological outcomes, as well as poor retention in HIV care and increased mortality. So I tried to show here how these internal factors act individually but also combined to cause non-adherence and an increase in the HIV treatment gap. So I'll move on to talk also about the external factors, beginning with gender inequalities. We have already heard, I think we spoke more about this yesterday when we were referring to adolescent girls, which are disproportionately vulnerable to HIV infection due to greater physiological risk, gender inequality, unequal gender norms, and gender-based violence, including intimate partner violence. So while HIV prevalence is about equal between girls and boys aged 10 to 14 in sub-Saharan Africa, you find that differences start to emerge when you get to age 15 to 19, with prevalence higher among girls in most countries. And I think these are important statistics to consider when we want to then make the interventions to target adolescent girls and young women. Then the other external factors that are playing a significant role in increasing this treatment gap, you talk of healthcare worker attitudes, where negative attitudes of healthcare workers affect adolescents more than adults, particularly those adolescents that are living with HIV. And studies have been consistent to show that adolescents often avoid engaging with health services, including HIV testing and treatment, due to distrust in healthcare workers related to judgmental attitudes and perceived lack of confidentiality. Then there are also knowledge gaps, where in sub-Saharan Africa, from the population-based surveys that were done, about 26% of adolescent girls aged 15 to 19 years and 33% of adolescent boys of the same age group only that had a comprehensive and correct knowledge of HIV and AIDS. So you find that these knowledge gaps also hinder access to testing and treatment of undiagnosed adolescents living with HIV, and also result in poor treatment adherence and continuity in treatment due to lack of understanding of the benefits of treatment. Then I'll move on to focus on the policy issues as well that affect access. There are case finding gaps, especially among adolescents. We find that coverage of HIV testing and counseling remains significantly low among young people that are aged 10 to 24 years, according to UNICEF. Then self-reported survey data from sub-Saharan Africa indicated that only 9% of adolescent boys aged 15 to 19 years and 13% of adolescent girls from the same age group had been tested for HIV and received the results in the past 12 months. So when you look at some of the strategies that we use for our case finding among adolescents, we talk in our programs of targeted testing. We also talk of index case testing and provision of testing in high-yield entry points. But despite all these strategies that we are utilizing, we continue to have case finding among adolescents being low. So it means we need to do more to find adolescents that are living with HIV, and there seem not to be enough linkages between health services delivery for adolescents and other social services in order to reach adolescents and services that address their holistic and complex needs. Then on the policy issues, I'll focus also on the age of consent to HIV testing. I'm not trying to reignite the powerful debate, I'll call it the Elena versus Wale debate that we had yesterday, but I'll just focus on the facts that I have on this one. That legal barriers, including age of consent, and I'm talking about HIV testing here, and parental consent laws continue to hinder access to services, including sexual and reproductive health services for adolescents and youth. Adolescents are often reluctant or afraid to seek services that require the consent of a parent or guardian, specifically the SRH services, including HIV. So age of consent to HIV testing services varies between countries, and the age of majority, which is the legal age at which an individual is considered an adult, is not necessarily also related to the age of consent in most countries. So when you focus on WHO guidance, it allows for HIV self-testing to be offered to adolescents 10 to 19 years old, amongst other groups, and research has also shown that allowing free adolescent access to HIV testing services is associated with higher testing coverage among adolescents. I don't know if that will make you revise your voting from yesterday. So this one is a busy slide, but I just wanted you to focus mostly on the column 1 and maybe column 3, which is just focusing on what I've been trying to explain now on how countries really differ when it comes to the legal age of consent to independent HIV testing and counseling among adolescents. So you'll notice that South Africa, for example, is at 12 years. We look at Mozambique at 16 years, Zimbabwe is at 16 years, Uganda 12, Ethiopia 15, Malawi 13, and these ages are continuously being revised across the countries. And I'm sure as policymakers are sitting, they go through that same debate as we had yesterday, as they try to find consensus on when adolescents can be allowed to consent for HIV testing. But these are some of the policy issues that then impact and affect HIV testing and increase the treatment gap, because adolescents just won't go for testing when they need consent from their parents, from what the researchers have shown. Then I'll also focus on criminalization and punitive laws as well, where punitive laws have been shown to block HIV service access and increase HIV risk. So you find that countries that criminalize key populations saw less progress towards HIV testing. Targets over the last 5 years with significantly lower percentages of people living with HIV knowing their HIV status and achieving viral suppression than in countries that avoided criminalization. So particularly underserved and populations are adolescents and young people from key populations. I think we spoke in depth around this yesterday, especially the LGBTQI community. So we have other harmful laws as well that include those around HIV exposure, non-disclosure, and transmission, as well as drug possession and use that are criminalized heavily in different countries, and the laws are different in different countries. So decriminalization is a critical element to end AIDS by 2030. However, despite the compelling evidence, we find that many discriminatory and punitive laws, they still remain, and they are varied across the countries. Then, last but not least, I'll also talk about non-involvement of young people. I think this conference has been so clear about young people saying nothing about us without us. So it is important for us to involve young people in our policy, but you find that more often than not, young people are often not involved in policies or consulted in policy making. And it has been shown through research that participation of young people helps to build trust among those served by the programs and to make programs more comprehensive and responsive to the needs of young key populations, as well as creating more enabling environments for HIV prevention. So I would like to acknowledge my boss, Nicola Willis, as well as who is the Zvandiri Executive Director, as well as my colleagues, Nicola and Vivian, who also had an input in this presentation and their comments. I would like to also acknowledge the organizers of this beautiful conference. I think you can agree with me that it has been a good time, and we're still having a good time here. These were some of the references that I used. Thank you so much.